Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Greg Peters, an immunologist and respirologist working in Saskatoon, discusses perioperative anaphylaxis. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So we're going to discuss the definition, epidemiology of perioperative anaphylaxis, recognize the most common causes of perioperative anaphylaxis and how their presentations differ, learn how allergists investigate the cause of perioperative anaphylaxis, and understand how anesthetists can work with allergists in the work of perioperative anaphylaxis. Okay, so case one, 73-year-old male. Profile, pre-existing coronary artery disease, stents, dyslipidemia, gout, hip replacement. His pre-op meds were aspirin, Plavix, Crestor, Perindopril, metoprolol, colchicine. He was getting a laparoscopic chole. He received Ancef and immediately pre-op, and then was induced with succinylcholine, lidocaine, Sufenta, propofol. Rocuronium was used shortly after that. Shortly after abdominal insufflation and initial dissection, the patient had a perforation of the gallbladder. Severe hypotension ensued. Surgery was abandoned. The patient was closed with a JP drain. He was treated with ephedrine and epinephrine. The intraoperative echo suggested a thick wall ventricle, and postoperatively, he was diagnosed with hypertrophic cardiomyopathy, which wasn't known about preoperatively. Also, post-op, coronary artery disease was confirmed, and he required stents. He continued antibiotic post-operatively and was discharged on Keflex with no issues. So, on the surface, you would think this was all cardiac. I mean, it sure sounds like it's all cardiac, but the intraoperative tryptase, which the anesthetist sent for, which I'm very thankful that they did, was more than 20. So, we ended up doing testing. He was quite positive to Ancef, despite the fact that he could tolerate Keflex. So this was a situation where Mr. JH had an allergy to the side chain of Ancef, but not to the core cephalosporin molecule. He could tolerate Keflex without problem, but the Ancef caused severe allergy. Succinylcholine, lidocaine were both negative. Propofol was negative, rocuronium was negative, and chlorhexidine was negative. Case two, 39-year-old male, pre-existing asthma and rhinitis, hikes regularly, not on inhalers. He was admitted with an MVA, hip and clavicle fracture. 3 days later, was supposed to go for repair of the clavicle fracture. If I recall, this was a Regina patient. He was on no pre-op antibiotics, induced with rocuronium and propofol. He quickly developed rash and hypotension. Surgery was abandoned. The post-op CT confirmed pulmonary emboli. Again, on the surface, it would seem that this was all pulmonary emboli. He was discharged home on apixaban, and decision was made to treat the clavicle conservatively. He didn't go back for surgery. So again, you would think this was all PE, but serum tryptase again was 17. That was the only clue, really, that this was anaphylaxis besides the rash. When we tested him, he was quite positive to rocuronium. In this case, I didn't even have to do intradermal testing. It was positive on the skin prick test alone, which is very unusual. Usually, skin prick test is negative, and you don't get a positive till you're well into the intradermals. But he was very, very sensitive. I didn't have to do the intradermal. Chlorhexidine, propofol, latex, succinylcholine, they were all negative. Case number 3. 31-year-old female, 2 previous C-sections, uneventful. She was getting a cholecystectomy, no pre-op antibiotics. She was induced with rocuronium, propofol, Sufenta, dexamethasone, lidocaine. Shortly after, she developed bronchospasm and rash. The rash and bronchospasm was treated with epinephrine, methylprednisolone, famotidine, Benadryl. Her condition improved. Surgery proceeded. She was stable. They went ahead with surgery. Postoperative tryptase, 20.7, which is normal is 11, so 20 is quite high. Skin tested her, found no cause for the event. Chlorhexidine, rocuronium, propofol, latex, lidocaine, all negative. So she is one of the cases where we were not able to find a culprit, and that's more common than you would think. So definitions, I won't belabor this. I think we all know what the perioperative time frame is and what a hypersensitivity is. Anaphylaxis, according to the 2020 guidelines, acute onset of illness with simultaneous involvement of skin, mucosal tissue, or both, generalized hives, pruritus, or flushing, swollen lip, tongue, and at least one of the following: respiratory compromise, circulatory compromise, or severe GI symptoms. Now, problems in the perioperative period, patients have drapes on, you don't necessarily see the skin, and you're not going to get any complaints about GI symptoms when they're anesthetized. So you're really looking at respiratory and circulatory compromise. And if you can see the skin, great, you might see a rash. The second definition, acute onset of hypotension or bronchospasm or laryngeal involvement after exposure to a known or highly probable allergen for that patient, even in the absence of typical skin involvement. Specifically does not include lower respiratory symptoms following inhalational allergen exposure, such as would be expected with asthma. So that is the exclusion in that definition. There are grading systems for anaphylaxis. There's several of them. Pick one and use it. Epidemiology. So the incidence of perioperative anaphylaxis, it's really unknown. So the ranges in estimates are from 1 in 250 to 1 in 20,000. The problem is the denominator. Nobody really knows how many procedures are being done. And that's the problem with most of these ranges. But what's published in the literature is highly variable. Mortality of perioperative anaphylaxis is very high compared to anaphylaxis at other times, 3 to 9%. Young boys and girls are equally affected, but by the time humans reach adulthood, women are more affected than men. The inciting agent remains obscure in 30 to 50% of cases. So even after full allergy evaluation, there's a third to half that are going to go undiagnosed. 60% of these are believed to be IgE mediated. The primary driver of the non-IgE mediated events, these would previously be known as anaphylactoid reactions, is direct mediator release from mast cells and basophils. I mean, opioids commonly do this, and you guys all know that. Complement activation, kallikrein activation are factors as well. Both IgE and non-IgE mechanisms can result in similar symptoms, and both can raise the tryptase level. So it's important to know that the tryptase level doesn't specify between these two. When you look at different types of drugs and what the mechanism is for the reaction, you can see that beta-lactam antibiotics, muscle relaxants, latex chlorhexidine, the blue dyes, and sugammadex, they will all cause IgE-mediated reactions. Vancomycin, radiocontrast media, opioids, those are typically more non-IgE mediated, so no testing is possible for those. Mechanism of allergy, again, you guys know this, but mast cell activators lead to vascular compromise. So you get vasodilation, and where that vasodilation occurs depends or dictates what symptoms you're going to get. When that happens systemically, you're going to get hypotension. When the vasodilation vascular leak happens in the bronchi, you're going to get bronchoconstriction. When it happens in the gut, you get intestinal problems, gut pain, diarrhea, vomiting. So the vascular leak is basically responsible for all your symptoms, and that's why epinephrine works so incredibly well at fixing this. So presentation usually occurs within minutes of induction of anesthesia. Cardiovascular respiratory compromise are the hallmarks. Cardiovascular collapse is the first sign in up to 50% of cases. Skin symptoms may be absent or obscured by drapes. Often the skin symptoms are a bit delayed, specifically with perioperative anaphylaxis. While it's one of the first signs with regular anaphylaxis, for whatever reason in perioperative anaphylaxis, it's often noted that the skin symptoms happen quite late. Gastrointestinal symptoms, if the patient's asleep, you're not going to hear about this. Allergy can be missed as hypotension because all the anesthetic agents that you give cause hypotension. So it's a capillary leak syndrome. You can paradoxically get bradycardia. Acute coronary vasospasm may be attributed to pre-existing coronary artery disease. Does anybody know what that's called? Allergy-inducing coronary vasospasm. That's right, yeah. Kuhn syndrome, yeah. And there was a case 10, 12 years ago that I had of Dr. Spafford's that had Kuhn syndrome. He had an intraoperative MI related, again, I believe it was ANSEF. Bronchospasm is more likely a symptom if the patient has pre-existing lung disease. Beta blockers and ACE inhibitors both can increase severity of perioperative anaphylaxis. They don't cause it, but they increase the severity of the disease. So presenting symptoms in blue and clinical features at any time in the red and white candy stripe. So hypotension is going to be the presenting feature in the majority of these patients. That's going to be your clue. Bronchospasm to a lesser extent, tachycardia, desaturations. Cutaneous symptoms, initially, the presentation is quite low, less than 10%. Eventually, by the end of the procedure or the resuscitation, about 50% of these patients are going to get some sort of rash. So you need to keep looking for it, and you need to look late for that rash. When it happens during surgery is very, very important to me when I'm trying to investigate this. So knowing when the symptoms started, because that will determine what drugs are most likely to have done this. And it's not really surprising or rocket science, this. The medications you give up front are more likely to cause allergy early in the picture. The medications you give late in surgery are more likely to cause problems late in the surgery. And there's some that you give in the beginning of the surgery that can cause problems late. For example, chlorhexidine and the intravenous opiates, they can present late, even long after you've given them. But the ones that will typically cause problems at induction are going to be the muscle relaxants, the intravenous anesthetics, and the antibiotics. So other things can cause similar symptoms. So a lot of these factors are anesthesia related, so irritation of the airway, side effects of the drugs, all common things, aspiration. You can have procedure-related problems, so more blood loss than expected, causing hypotension, amniotic fluid embolism, overdose of oxytocin. And then there's also patient comorbidity-related factors. You can have hyperactive airways, pulmonary emboli, cardiac disorders, like our fellow that had pre-existing coronary artery disease and HOCM that wasn't known. Mast cell disorders, those are terribly rare though. They get blamed a lot more than they're actually responsible. So we're going to talk specifically about numerous agents that cause anaphylaxis and how I look at this and try and sort it out after the fact. Typically, we want to see patients at least 4 weeks after the anaphylactic event, because if we test them too soon, then the IgE can be depleted and we may end up with false negative tests. So we usually bring them back about 4 weeks later. So it's not that I'm trying to be ignorant or ignore your patient, but we try and give them a bit of time to recover before we see them. When we look at most commonly responsible agents, it depends on what country you're from. The muscle relaxants, they are the biggest cause in Europe. You can see here 41% in Belgium, 55% of cases in Norway, 60% in France. Okay, so in Europe, they rule supreme. In the US and the UK, antibiotics are by far and away the biggest culprit. And I don't know if that's just a factor that the US uses more antibiotics preoperatively than Europe does. I presume that's the case rather than some other factor, but I don't know that to be certain. In the US, 50 to 60% of perioperative anaphylaxis cases are related to antibiotic use. 47 in Britain, then only 15 to 20% in Belgium and France. Blue dyes, 2 to 5%. Chlorhexidine, less than 10% of cases. And that would round out the most common ones. So, neuromuscular blocking agents, historically the most common agent to perioperative anaphylaxis. Again, many places in Europe, it's 50 to 70% of events. In the US, it's less frequent. They can cause anaphylaxis both through IgE and non-IgE mediated mechanisms, although the IgE mechanisms reign supreme here. Sensitization is through the tertiary and quaternary ammonium structures. These structures are also found on cosmetics, over-the-counter medications, disinfectants, and foods. That's mainly the reason that we theorize that women are more likely to get perioperative anaphylaxis than men, is because of this. Cosmetics will increase your sensitization to these products, and then women are obviously more commonly exposed to these cosmetic products than males. When you look at hairdressers, there's much higher rates of sensitization. Before puberty, there's no difference in the rate of allergy between males and females. So boys and girls affected equally, men and women, it's discordant. In Norway, the rates of NMDA allergy were higher among users of full codeine, which is an opioid antitussive, and rates of allergy to NMDAs were declining once that full codeine was taken off the market. So again, more evidence that other agents are sensitizing our patients. So there are 3 classes: aminosteroids, benzoyl-isoquinolones, and succinylcholine is kind of by itself. Cross-sensitization is 60 to 70% among these agents, although only 7% of patients would have sensitivity to all of them. Pancuronium often cross-sensitizes with vecuronium. Succinylcholine will cross-sensitize with galamine. Cisatracurium, not surprisingly, cross-sensitizes with atracurium. From what I can see that gets referred to me, it looks like rocuronium is used 95% of the time plus. Yeah, I'm seeing some nods. In general, rocuronium and succinylcholine have the greater risk of allergy. Atracurium, cisatracurium, pancuronium, less risk of allergy. Atracurium has the greater risk of direct histamine release, however, so the so-called anaphylactoid reaction. Moving on to antibiotics. In France, antibiotics account for 20% of events, while in the US, it accounts for 40 to 55%. Penicillins and cephalosporins are the most common culprits. They're also by far and away the most common antibiotic that's going to be given perioperatively. Vancomycin and fluoroquinolones have been implicated, but they're difficult to confirm because we don't have proper testing for those antibiotics. Reaction to antibiotics are generally within 5 minutes, so 74% within 5 minutes, 92% within 10 minutes, 97% within 15 minutes. So you're not really looking for late reactions with the antibiotics. They're going to happen early. So antibiotics are also the drug which we have the most validated testing for. We do it with both skin prick tests and intradermal tests. For penicillins, you have to do both the major and minor components. So when we talk about penicillin, most people who react to penicillins won't react to the penicillin molecule itself. They react to the breakdown product of penicillin. And there are 3 components to those breakdown products, and that's the major and the minor components. So those are very important to be tested. If you just do your skin testing with the penicillin molecule itself, you'll get tons of false negatives. And also, allergy to antibiotic can be side chain specific. So I've seen many patients who will react to Ancef and not have an allergy to the other cephalosporins, and that's probably the antibiotic for which I see the most side chain specific allergy. So the fact they can tolerate Keflex doesn't completely reassure you that it's not an Ancef problem. Just like our fellow in case 2 there that went home with Keflex and had no issue, but it was Ancef that was positive. Latex. So natural rubber products are made from the Hevia brasiliensis tree. It was a very common cause of anaphylaxis in the 90s due to the rapid production of gloves and other healthcare products during the 80s and 90s because of the HIV pandemic. Gloves in the 80s and 90s had high protein content, more likely to cause allergy. In the 2000s, there was a steep decline in latex allergy. In fact, I can't remember the last time I had a positive latex test. It was probably at least 5-6 years ago. It's quite uncommon these days to have a positive latex test compared to the 90s where it was very, very common. And so the difference in production has made a huge difference in allergy. Typically, reactions to latex occur late in surgery after there's been significant mucosal exposure. Allergic individuals should be done in a latex-free setup, and if possible, it's the first case of the day. And there is a commercial extract for latex testing. It's pretty easy to test for latex. How commonly do you guys use latex in the OR anymore? Is it common, or is pretty much all the cases latex-free? Everything's latex-free? I'm getting nods. Yeah. Pardon? One drain. Oh, okay. Oh, okay. Okay. Yeah. Disinfectants. So this is something that gets overlooked many times, but honestly, it's a fairly major cause of allergy perioperatively. I've seen numerous cases of chlorhexidine allergy. It can occur later in cases. It doesn't have to be immediate. It's more commonly seen in males and during urologic procedures, presumably because of the amount of chlorhexidine, I'm guessing. Impregnated CVC catheters have to be thought of as well. They can be a culprit. There's more absorption through mucosal surfaces. There's few cases of providing iodine sensitization. I have never seen a case of that in all my years. Bacitracin has been reported as well. Typically, that's more a delayed reaction, though, like a day or two after you would get bacitracin that you would have a rash to that. Blue dyes. They're used in sentinel lymph node identification. Most commonly, you've got patent blue and isosulfan blue. They differ structurally from methylene blue, but even so, there's been cross-reactivity. This is often delayed compared to the medication reactions, and it's perhaps because of slower absorption from the lymphatics and when you're actually injecting the dye during the procedure. I have seen at least 1 or 2 blue dye allergies over the last 15 years, but it's not been that common. Sugammadex is reported as causing allergy. I have never seen a case, but we're talking 0.0016% to 0.02% of perioperative anaphylaxis. Cyclodextrin is a related molecule, and it's found in food additives and may be sensitizing, so that may be why people get allergy to Sugammadex. There's reports of patients reacting to a rocuronium Sugammadex complex, but not to the Sugammadex by itself. To me, that's an odd statement, because why are you giving Sugammadex except to absorb the, oh, thank you so much. Why are you giving it except to bind the rocuronium? It would seem to me that there would always be complexes there, but neostigmine can also cause reactions as well. It's just FYI, but that's pretty rare. Again, I put this up because to me, it's just such a cool looking molecule. But it basically completely surrounds the rocuronium, which I guess you guys know already. Hypnotics. So medications such as propofol, ketamine, midazolam, etomidate, they can cause allergy, but they're honestly quite rare. I test propofol all the time, never seen a case. I've never heard of a case of midazolam allergy. In fact, I don't test it. Sorry, we have a question?
When you say all the time, how many, at the end of 1,000?
No. So with every perioperative case that I would see where propofol's been given, I would usually test it. But number of cases that I would test in a year would be 5 or 6 per year. Yeah. Ketamine, midazolam, etomidate, I have not been testing those. They would be hard to test, and I don't know that proper protocols would exist. And midazolam allergy would be almost unheard of. Barbiturates have caused problems in the past, but I mean, nobody uses those anymore. Benzodiazepines, very, very rare cause of allergy. And as a class, these will cause 2% or less of your perioperative anaphylaxis cases. So these are not common causes. The propofol most of the time gets tested simply because of the link with soy and egg. Again, propofol, lipid vehicle, there's soybean, egg, lecithin, and glycerol in there. So there's been questions raised if people have egg or soy allergy or peanut allergy, are they going to all of a sudden react to the propofol? Mostly this has been disproven. The soybean is purified oil, and so there's not a lot of protein in there. The egg is lecithin, which is from the yolk, and people, when they react to egg, they react to the egg white almost exclusively. So true allergy to propofol is likely secondary to the two isopropyl groups on the molecule itself and not related to the egg and the soy. So I won't belabor that point, but that's what everyone worries about. So opioids. True anaphylaxis to opioids is rare, with an incidence of 1 in 100,000 to 1 in 200,000 perioperative reactions. There's no good way to test this. Opioids directly stimulate mast cells to release histamine. So many people will get positive skin test to opioid and not have an allergy. The test is useless. Usually you'll get cutaneous symptoms with this direct mast cell activation. You'll get urticaria, itching, may get some vasodilation. You may get nonspecific activation of mast cells from the opioids. Morphine and Demerol are particularly bad, I'm told. Very few case reports of true anaphylaxis to codeine and fentanyl. And again, skin testing, you really can't do it. Colloids, albumin, dextran, hetastarch, gelatin account for 1 to 4% of perioperative reactions. Gelatin and dextran are most likely to cause reactions. Albumin is least likely to cause reactions. Positive skin tests and anti-gelatin IgE are found in gelatin-sensitive individuals. Circulating anti-dextran IgG antibody can be found in those with dextran allergy. There's no known cross-reactivity between these groups. I have not had to test anybody to these. That's not been something I've seen yet. Finally, we're going to talk about local anesthetics. Extremely rare case of anaphylaxis. So for all the people that come in saying I'm allergic to lidocaine, most of the time this is rubbish. Most commonly, their symptoms are from sympathetic stimulation, vasovagal reactions, psychomotor reactions, also a direct effect from where the procedure is being done. Most often it's from dental procedure, and they say, well, I swelled up like crazy, like a chipmunk after the dental procedure. Well, that's because the dentist just did a bunch of work there. Less commonly, you can get systemic toxic effects if too much of this is given or it's all of a sudden intravascular. Very rarely, you get delayed reactions, contact dermatitis to the site of administrations about 48 to 72 hours after. Now that I've seen maybe 6 or 7 times in the last 15 years. But generally, they're not something that you guys will be dealing with intraoperatively. It's something that you might see when a patient comes to pre-op clinic and says they have lidocaine allergy, and they tell you, well, I had this massive eczematous rash where they used the lidocaine 2 days earlier. You can do skin testing for local anesthetics. I've had delayed reactions from that skin testing. I do this one all the time because the dentists are always sending this in. But I have not yet seen a single case of IgE-mediated reaction to lidocaine or the other local anesthetics. So it's extremely, extremely rare. There's 2 types. You can have the group 1 benzoic acid ester agents, including benzocaine, procaine, tetracaine. I don't think any of those are used to a significant degree. Then you have your group 2 amide agents, including lidocaine, bupivacaine, mepivacaine, which are the ones you'll be using with your local anesthetics all the time. Heparin. So you can get a delayed hypersensitivity, dermatitic rash 2 to 4 days later, starting at the site of the infusion. It rarely will cause immediate reactions and anaphylaxis. HIT can occur in approximately 1% of cases. First presentation is approximately day 5 of treatment with HIT. Subsequent doses can cause immediate HIT symptoms, so that may happen much faster on the 2nd and 3rd exposure. Immediate IgE reactions may occur in isolation or in conjunction with heparin-induced thrombocytopenia hit. And skin testing is possible. Thankfully, I've not had to do this yet either. It's not something that's been referred to me. Protamine, rare cause of both immediate and delayed true hypersensitivity. It can be confused with heparin reactions because, like I said, the heparin reactions can occur late, so you can confuse those two quite easily. Blood products. So urticaria is seen in 0.5% of all transfusions with frozen plasma. You guys will see that all the time, I'm sure. Because plasma is present in small amounts in other blood products, they can get allergic reactions as well. Use pre-treatment with diphenhydramine in those with previous reactions. Most of the time you can treat your way through these things. True anaphylaxis to blood products is also extremely rare, 0.06% of transfusions. True allergy to radiocontrast dyes are rare. Most of the time this is anaphylactoid reactions from direct stimulation of mast cells. Positive skin tests are extremely rare. Testing for this is tricky and rarely done. Last thing I wanted to talk to you about is tryptase. Please, please, please order tryptase levels. It is so helpful sorting this out after the fact. Tryptase is a mast cell protease that's preformed and released when mast cells are activated. It peaks 15 minutes to 120 minutes after onset of symptoms and signs of anaphylaxis. The half-life is about 2 hours. So you want to get the level drawn within 20 minutes to 3 to 4 hours after the start of symptoms. Some textbooks say 3 hours, some say 4 hours, but basically as soon as you think about it and the patient's stable enough to do it, try and get a blood sample for a tryptase level. You don't want to do it too soon in that first 15 minutes because you might get a false negative. It's elevated in most anaphylaxis episodes of sufficient severity to cause hypotension. That's the key. Anaphylaxis that's not severe enough to cause hypotension, sometimes you don't get a positive tryptase level. Also, it's more likely to get an elevated tryptase level with allergens that have been injected or insect stings. Allergens that are ingested orally are less likely to cause an elevated tryptase level unless you get hypotension. And that's because of differences in the mast cells in the gut versus the mast cells elsewhere in the body. Tryptase is generally at higher levels after parenteral exposure as well compared to enteral exposure. And the tryptase level does not distinguish between allergic and pseudoallergic or anaphylactoid reactions. They both can increase tryptase level. So a bunch of studies have looked at different cutoffs and what is considered a positive. I won't belabor this, but I mean, as you would expect, the higher the cutoff, the less sensitive the test is, the more specific it is, which makes 100% sense. Our lab uses a cutoff of 11.4. There are other things that can elevate your tryptase level besides allergic reactions and anaphylactoid reactions. So mast cell disorders, extremely rare, but can happen. Familial hypertryptasemia, more common. You don't know about this because who checks a tryptase level on a normal, healthy individual, but some people just have higher tryptase levels at baseline. Chronic kidney disease can elevate your tryptase level because the tryptase is cleared through the kidneys. Hematologic malignancies can elevate tryptase level, but then they're generally chronic elevations of tryptase, not just during events. Cardiovascular diseases can elevate tryptase level. Eosinophilic GI disorders, they're extremely rare, but can happen. Parasitic infections, not a big problem in Canada, but elsewhere in the world, that can be a consideration. Gaucher's disease, and then problems with the assay. So IgE antibodies to drugs administered during anesthesia were detected in 125 of 158 patients with increased mast cell tryptase concentrations, but were only identified in 7 of 143 patients who did not have an increase in mast cell tryptase. So I'm here to help. So please refer these patients to me. I want to see them. And help me help you. A few things I ask. If you can please, please, please send me the anesthetic record. Just a photocopy of the anesthetic record is super helpful. It gives me the graph with the timeline of when the drugs were administered and when the symptoms started and when the hypotension started. When I just get a discharge summary, or worst, yes, an operative report, the surgeons don't include any of this information in it, and I just don't know. So a copy of the anesthetic record is great, and it's so easy for you guys to fax to me, but when I have to look for it and call health records, it can take weeks to get back. And sometimes it's been not found, and I've had troubles. So that would be super helpful. Second, a little short dictated note about the timeline of the meds given. There's been a few of you where the anesthetic record has been really, really hard to read. Tryptase level, we talked about that. If you can order a tryptase level at some point, you know, again, not when things are crashing, but once the patient is stabilized a bit, if you can get a tryptase level, super helpful for me after the fact. And the last thing, if you can just, in that dictated note, just include a contact information, because it's sometimes been really hard to get a hold of you guys.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.